Hello, my name is Jeff Knight and I'm a general dental practitioner from Melbourne. Dental implants play an important role in restorative dentistry. However, over the years, many patients have asked me if there are simpler, less invasive and less costly alternatives. The following bridging technique has a unique anchoring system within the enamel of the abutment tooth, resulting in a minimally invasive, less costly procedure that provides patients with the same aesthetic and functional outcomes as a dental implant. This young woman had been uncomfortably wearing a plastic denture for many years and was seeking a more secure replacement. A small restoration was removed from the mesial of the abutment tooth and incorporated into a tea preparation prepared 2/3 of the way across the lingual surface towards the distal and about 1.5 millimeters deep, mostly within enamel. This graph shows the three principles of tooth preparation. Prepare enamel to a depth of about 1.5 millimeters. The anti-rotation T design stabilizes the pontic and the retainer in three directions. A slightly increased width and depth of the preparation at the margin to enable thickening of the retainer in this area and improve the strength of the bridge at the isthmus. A triple tray impression technique is employed. Heavy body impression paste is placed into the upper and lower sections of the tray and light-bodied impression paste over the abutment area. The patient is then asked to close in a centric position once the tray has been inserted. Remove the tray once the impression paste has set. Observe the outline of the preparation within the abutment tooth, about 1.5 millimeters. Shade taking is achieved by photographing a Vita shade guide against the abutment tooth and emailing the photograph to the ceramist for colour matching. A temporary dressing is placed into the preparation prior to returning the denture and dismissing the patient for 10 working days until the prosthesis is ready for insertion. At the insertion visit, after removal of the denture, the temporary dressing is carefully removed with a high-speed flat fissure burr. The abutment tooth is then etched for 5 seconds with 37% phosphoric acid and thoroughly washed and dried. The bridge is next dried into the preparation to ensure a good fit of the retainer and that there is a correct colour match of the pontic. A mylar strip is next inserted on the distal surface of the abutment tooth and a small amount of resin modified glass ionomer cement is placed into the preparation and on the proximal surface. A small amount of resin modified glass ionomer cement is placed upon the retainer. With narrow incisors, it is sometimes advisable to place a white opaque over the fitting surface of the retainer to block out any metal shine through on the labial surface of the abutment tooth. After the bridge has been inserted and gently pressed into position, another small increment of resin modified glass ionomer cement is placed over the retainer, followed by a small amount of composite resin. Composite resin is further placed into the join between the retainer and the pontic, and a perio probe is used to remove any excess cement from the gingival margin of the proximal surface. The mylar strip is then gently folded over the lingual surface of the retainer and pontic, and the patient is asked to close firmly into centric occlusion to achieve the correct positioning of the bridge. The steps for inserting the indirect internally retained bridge are summarised as follows. Firstly, etch the preparation for 5 seconds, wash and dry. Next, insert a suitable resin-modified glass ionomer cement into the preparation. Next, insert the retainer and the pontic. Next, cover the retainer with a small amount of composite resin. Next, overlay the retainer and pontic with a mylar strip and have the patient close firmly in centric occlusion. Next, photo cure the labial section for 10 seconds, ask the patient to open and photo cure the lingual surface for a further 10 seconds. Labial contouring is achieved with an 8-fluted tungsten carbide burr under a water spray. The occlusion is then checked in centric, lateral and protrusive movements and adjusted with a high-speed diamond burr under water spray. Check the occlusion again and carry out the final contouring with a slow-speed diamond sphere to ensure there are no interference on the lingual surface. The bridge is also finally finished using a rubber cup on both the lingual and labial aspects of the tooth. Proximal surface of the adjacent tooth is checked with dental floss and also would assure that there is no debris under the pontic or against the proximal surface of the abutment. This minimally invasive bridge easily matches the aesthetics of a dental implant. With less clinical time and laboratory fees involved to make this bridge, dentists can now offer their patients a comparable clinical outcome to a dental implant with substantial savings in both costs and the time involved.